Hello friends, so today we are discussing case number 2 from the book Based Medical Microbiology. Now, a neonate is brought to the emergency department by her parents. She has been crying for the past day and has developed a fever and an erythematous rash. Upon examination, the doctor notices redness of skin and widespread formation of fluid-filled blisters that are thin-walled and easily ruptured. There is no mucosal involvement. The patient is positive for Nikolsky's sign. Skin biopsy microscopy reveals lesions are intraepidermal. Blood culture and culture of blister fluid are negative. Now, think yourself that what could be the possible clinical diagnosis, what will be the causative agent, what is the pathogenesis, how you are going to investigate this, which treatment strategies you will adopt, and how you can prevent this condition. I give you few minutes or few seconds. Minutes it would be too much, but few seconds to come to at least possible diagnosis. So the diagnosis is Staphylococcal scalded skin syndrome, and the causative agent is Staphylococcus aureus. In neonates, Ritter's syndrome is the most severe form of scalded skin syndrome. Now, what is the pathogenesis? In newborns or in at-risk adults, a cut in the umbilicus or a skin wound promote the local Staphylococcus aureus epidermal infection. As we know, Staphylococcus aureus is a skin flora. So any wound or any cut may introduce this and promote local colonization and infection. This Staphylococcus aureus now release toxins. These are exfoliative toxins, ETA and ETB. And this toxin they spread systemically, and their target is desmoglein. Now, desmoglein is a keratinocyte in the superficial epidermis that plays a critical role in cell-to-cell adhesion. Now, because this desmoglein is destroyed, now cell-to-cell adhesion is not possible, and this leads to loosening of cells in superficial epidermis, which causes edema as well as blisters. This further will lead to cell death in form of intraepidermal necrosis, and ultimately the skin sloughs off. That leads to skin peeling, as in this case. Because of skin cells are lost, there is too much fluid loss, intracellular fluid loss, which leads to dehydration, and that can lead to secondary infection as well as sepsis. In the usual course of action, the skin typically heals in 2 weeks duration with minimal scarring. But mortality rate is 5% in children and more than 50% in adults. So condition is more severe in case of adults. Nikolsky's sign is a skin finding in which the top layer of skin slip away from lower layers when rubbed, and it is pathognomic for pemphigus, toxic epidermal necrosis, and staphylococcal scalded skin syndrome. And this sign basically differentiate intraepidermal blisters from subepidermal blisters. So in this case it was already given that it is intraepidermal lesion, but if it is not given, then also we should come to that conclusion that lesion is intraepidermal because Nikolsky sign is positive. But that has 3 differential pemphigus, TEN, that is toxic epidermal necrosis, and staphylococcal scalded skin syndrome. Now, most cases occur in children younger than 2 years old, mostly as outbreaks, especially in nurseries. And children are at high risk because of their immature renal system, lack of immunity, and absence of maternal antibodies in those who are not breastfed. Adults rarely develop this syndrome because we have developed antibodies to this toxin. But cases in adults are typically seen if your immunity is low. That means in immunosuppressed cases like HIV or AIDS. severe renal impairment or renal failure, and those with cancer patients. Now, patients with renal failure, they are unable to excrete the exotoxin and hence develop the disease. So, differential diagnosis, first of all, there is no mucosal involvement, which was very evident in the case itself. So, it differentiate scarlet fever, toxic shock syndrome, toxic epidermal necrolysis, Stevenson-Johnson syndrome, and pemphigus. There's all this condition along with skin. Mucous membrane is always involved, right? SSS is intraepidermal, while TEN cause necrosis of entire epidermis. SSS's rash is more tender and exfoliative in nature than scarlet fever rash. In Petico, staphylococcal toxin remain localized at one area, while in SSS it is sprayed via systemic circulation, so this is more kind of generalized disease. So let us understand it with help of a differentiating chart. So we have erythematous rash with Nikolsky sign positive. If Nikolsky sign is negative, then what could be it? First, let us see what if it is positive. Then see whether fever is there. In our condition, fever was there, so it is staphylococcal scalded skin syndrome in children, and in adult, it is toxic epidermal necrolysis. If fever is not there, then it could be TEN, that is toxic epidermal necrolysis. If Nikolsky is negative and person is having fever, then it could be toxic shock syndrome involving mucosa also. It could be adult Kawasaki disease with children and swollen hands, and scarlet fever, that is sandpaper rash, mucosa, afebrile anaphylaxis, scomorbid poisoning, and alcohol flush. In these three conditions, there is no fever. Investigation: skin biopsy microscopy shows site of cleavage in the skin, whether it is intraepidermal or antiepidermis is involved. So it is superficial or intraepidermal in case of SSS, while in TN the antiepidermis is involved. If you do complete blood count, you do differential urinalysis if you are suspecting sepsis along with it. Serum electrolyte if dehydration is suspected. Blood culture and culture of blistered fluid are usually negative, so it will not yield any pathogen most of the time, but we should do it to rule out other possibilities. Treatment: fluid replacement to treat the dehydration, emollient and non-adherent dressing for smooth healing of the wounds. Avoid silver sulfadiazine because it increases the systemic absorption of this drug and result in toxicity. Now, what is the role of antibiotics? There is no role of topical antibiotics, and systemic antibiotics, that is usually in form of intravenous antibiotics, they are needed in severe cases, and oral antibiotics in mild cases. Now, if it is MSSA, that is methicillin sensitive staphylococcal aureus, then flucloxacillin is a good choice. If it is MRSA, then vancomycin should be suspected. And there is high prevalence of community acquired MRSA or initial treatment failure, which points towards that it could be MRSA. Now, along with this, as earlier also we have discussed in toxic shock syndrome, you have to give something to stop the toxin production. So clindamycin is an excellent choice, though it is a bacteriostatic agent, but it has excellent skin penetration and it is used to treat cutaneous staphylococcal infection. It also being a protein synthesis inhibitor, it inhibits the production of bacterial toxin, making it a preferred agent for toxin mediated disease such as staphylococcal scalded skin syndrome. To avoid resistance, we always use it with combination therapy along with penicillin or vancomycin. How we can prevent this? Contact precaution with strict hand hygiene to prevent outbreaks in hospital should be tried. Thank you.